Hey guys, today I want you to picture two stories playing out quietly, invisibly inside the human brain. In one, a vessel begins to clog. Blood slows, swirls, then stops. In the other, a vessel tears. Blood gushes where it shouldn't, flooding tissue never meant to hold it. Two different events, two different strokes. But to the person experiencing them, they might look the same until they don't. So before you get comfortable, take a moment to like the video and subscribe, but only if you genuinely enjoy what I do here. Also, let me know where you're tuning in from and what time it is. I'm always curious to see how far these conversations reach. Now listen carefully to see if you and your family members see these signs. Let's begin with the basics. Ischemic strokes happen when blood flow is blocked, usually by a clot. Imagine a pipe narrowing with cholesterol until a lump forms that finally plugs it shut. No more oxygen, no more glucose. The brain cells on the other side begin to suffocate within minutes. On the other hand, hemorrhagic strokes happen when a blood vessel bursts from pressure weakness or trauma. The blood doesn't go where it should. Instead, it floods into brain tissue, increasing pressure and damaging from the outside in. The brain isn't just starved, it's also bruised. Here's the split: about 87% of all strokes are ischemic. That's the common type. But hemorrhagic strokes, while less frequent, are often more severe and deadly. Both are medical emergencies. Both demand fast action. But the internal mechanics blockage versus bleed create very different challenges for doctors and outcomes for patients. There's a strange but telling metaphor I sometimes share with patients. An ischemic stroke is like a drought, slow and dry. A hemorrhagic stroke is like a flood, fast and violent. Same brain, different kind of storm. It's easy to confuse the two from the outside. Slurred speech, weakness, numbness, they overlap. That's why imaging like CT scans or MRIs are critical within minutes of arrival at the hospital. You can't treat what you haven't seen. And giving the wrong treatment, say a clot-busting drug to someone who's bleeding, can be deadly. Here's a quirky real-world tidbit. Some people with hemorrhagic strokes report hearing a pop or snap in their head before symptoms start. It's rare, but real. That sudden awareness, like a rubber band breaking in the dark, can be the only hint that blood has broken through. Two strokes, two opposite causes. But in both, the brain is under siege. And you or someone you love may only have minutes to recognize which battle has begun. Picture your brain as a vast, intricate city, millions of roads all carrying essential supplies. Now imagine one morning, without warning, a major highway shuts down. No traffic gets through. Buildings further down the line start to lose power. Lights flicker, functions stall. This is the beginning of an ischemic stroke when blood flow is obstructed. The blockage can come from a thrombus, a clot that forms right at the site, or from an embolus, a clot that travels from somewhere else, like your heart or neck, and lodges into a narrower vessel in the brain. Either way, the effect is the same oxygen can't reach its destination, and in a matter of minutes, brain cells begin to die. Now imagine something different. A water main suddenly explodes. It's loud, violent. The water doesn't just stop flowing. It floods into basements, ruins, machinery, soaks everything nearby. That's a hemorrhagic stroke, not about absence, but excess. Blood escapes the vessel and damages surrounding tissue by sheer pressure and chemical irritation. In ischemic stroke, the key word is blockage. In hemorrhagic, it's bleeding. Both are time bombs, but they detonate in different ways. Here's something you might not expect. During those early moments, your body often doesn't feel pain. The brain itself lacks pain receptors. So while parts of it are suffocating or swelling, you might not feel it the way you would a broken bone. What you notice are the effects like garbled speech, sudden weakness, or a fall. There's also a silent danger in both the penumbra. This is the zone around the damaged core that's not dead yet, but teetering. In ischemic strokes, if we restore blood flow fast enough, we can save this area. In hemorrhagic strokes, if we stop the bleeding and reduce the pressure, we can minimize permanent injury. A quirky fact here: researchers have noted that some people having a stroke will suddenly crave sweets or develop odd food preferences in those early moments. It's rare, but it's one of those strange brain misfires that tells you something isn't right. And here's a deeper truth in both types of stroke. The first 10 to 20 minutes after symptoms begin are like the opening moves in a chess match. Decisions made then, whether to sit, lie down, or call for help, shape the entire outcome. So when blood stops or spills, the race begins. Your brain isn't waiting. It's losing, unless someone intervenes. You notice something is off. Maybe it's your spouse slurring a word or dropping a fork. Maybe it's you pausing mid-sentence because your thoughts don't quite make it to your mouth. These signs are often subtle at first, but they matter because some symptoms lean ischemic and others whisper hemorrhagic, if you know how to listen. Ischemic strokes often begin quietly. You might feel weakness in one arm, or your smile becomes uneven. You can still talk, still think, but something doesn't feel quite right. Your grip loosens, your coordination slips. It's like a circuit is dimming somewhere inside you, but it hasn't gone out completely. Hemorrhagic strokes, on the other hand, tend to hit like a wave. People describe a sudden intense headache, not just pressure, but pain. It might feel like a thunderclap or a spike behind the eyes. Nausea, vomiting, or sudden collapse can follow. If someone says, "This is the worst headache I've ever had, and it's out of nowhere," you need to act. Now here's where it gets tricky. The overlap. Both types can cause speech problems, facial drooping, and confusion. You won't be able to tell just by looking if it's a clot or a bleed. That's why doctors use the same protocol. At first, get the person lying flat, check vital signs, get imaging. But sometimes the clues are in the pattern. Ischemic strokes might progress slowly, symptoms worsen over 30 to 60 minutes. Hemorrhagic strokes often hit with sudden profound disability. One moment you're fine. The next your vision is gone and your legs won't move. Here's a lesser-known sign: seizures can occur more commonly with hemorrhagic strokes. The blood irritates the brain, triggering uncontrolled electrical activity. If someone suddenly seizes for the first time ever, especially if they're older, it may not be epilepsy. It could be a bleed. And another one, neck stiffness or difficulty looking toward light, may hint at bleeding near the brainstem or ventricles. We often associate that with meningitis, but hemorrhagic stroke can cause similar meningeal irritation. A quirky tip: watch how someone reacts to sound. Ischemic strokes tend to dull responses. Hemorrhagic strokes, especially when they affect pressure, may cause hypersensitivity to noise or light, as if the whole brain is overstimulated. But no matter the details, your job isn't diagnosis. It's urgency. If something changes suddenly, speech, strength, balance, vision, don't debate. Call for help. Because behind every symptom is a clock, and your brain hears it ticking even when you don't. Now imagine this: two patients arrive at the ER within minutes of each other. Both are struggling to speak. Both have facial drooping and weakness in one arm. But their brains are facing entirely different emergencies, and the treatments they receive could not be more different. For the first patient, a CT scan shows a blockage, a clot lodged in a major artery. The medical team prepares to administer TPA, a powerful clot-busting drug that can dissolve the obstruction and restore blood flow. Time is critical. If it's been less than 4.5 hours since symptom onset, this drug can literally save brain cells. Sometimes we even use advanced techniques like mechanical thrombectomy, guiding a catheter through blood vessels to physically remove the clot. But now shift to the second patient. Their CT scan shows bleeding in the brain, a hemorrhagic stroke. For them, TPA would be fatal. It would worsen the bleeding, increasing the pressure and the damage. Instead, the team focuses on stopping the bleed, lowering blood pressure, reversing any blood thinners, and sometimes even surgery to relieve pressure or remove pooled blood. Same symptoms, different causes, completely different treatment paths. This is why stroke teams don't guess. We image, first treat second. There is no shortcut here. The inside matters more than the outside, a fact many don't know. In some hemorrhagic strokes, doctors use a treatment called coiling or clipping, tiny surgical procedures that reinforce weak blood vessels, especially if the stroke was caused by an aneurysm. These techniques are precise and life-saving, but only useful if the patient arrives in time. And here's something quirky but true: a stroke mimic like a migraine seizure or even low blood sugar can sometimes fool the best clinicians. That's why imaging and rapid testing are essential before committing to high-risk interventions. In ischemic stroke, every second you delay means more brain tissue dies. In hemorrhagic stroke, every second allows pressure to build, increasing the risk of coma or death. The urgency is universal. The actions are not. Think of it like two houses on fire. One is starved of oxygen, the other is flooded with it. You wouldn't fight them the same way, and neither does your medical team. When you or someone you love arrives in that hospital room, those first 15 minutes could mean the difference between walking out or not walking at all. What we do next depends entirely on what we see inside. The storm passes. You're alive. You're in a hospital bed surrounded by monitors, wires, whispers. And while the worst is behind you, the road ahead recovery therapy vigilance has only just begun. Because when it comes to strokes, the aftermath can be as defining as the event itself. If your stroke was ischemic, recovery often focuses on regaining strength, speech, and coordination while managing risk factors that may have caused the clot in the first place. That means blood thinners, cholesterol meds, blood pressure control, and lifestyle changes. Quitting smoking, watching salt, exercising again, gently but consistently. If your stroke was hemorrhagic, recovery may involve deeper challenges. Brain swelling takes time to subside. Surgery sites need healing, and the risk of rebleeding, especially in the first few days, requires tight control. These patients often spend more time in ICU, more time in rehab, more time just waiting for the fog to lift. A powerful difference between the two is recovery predictability. Ischemic stroke survivors tend to follow clearer patterns. We can often forecast recovery speed based on stroke size and location. Hemorrhagic strokes are wilder. Bleeding can impact deep brain structures unpredictably, and pressure damage might linger long after the blood clears. Now here's something many don't expect: emotional shifts. After both kinds of stroke, especially hemorrhagic patients may experience profound personality changes, anxiety, depression, or sudden tearfulness. It's not weakness, it's wiring. The emotional centers of the brain get rattled, and the chemicals that regulate mood can become unbalanced. One eerie condition that follows some hemorrhagic strokes is pseudobulbar affect, where someone cries uncontrollably or bursts into laughter at inappropriate times. It's not mental illness, it's neurological misfiring. As a doctor, I always tell families love the person, not just the behavior. The mind is healing, the soul is intact. But there's hope, so much hope. The brain is astonishingly plastic. Neural pathways can be rebuilt, rewired, or rerouted. Speech returns. Strength improves. Personalities re-emerge. Some patients even report becoming more creative, more focused, or more empathetic after surviving a stroke. It's like facing death opens a new clarity. And here's a final quirky insight. Some stroke survivors describe a sensation of re-seeing life, not just gratitude, but literal sensory changes. Food tastes stronger, colors appear more vivid, music feels deeper. These aren't hallucinations, they're signs of a brain rediscovering itself. The path isn't easy, but it's forward. With therapy, care, patience, and awareness, recovery isn't just possible, it's powerful. Now slow your breathing, let this final moment settle. You've learned the difference between ischemic and hemorrhagic stroke. You've seen inside both storms, and now you carry the knowledge to recognize, react, and respond. Maybe for yourself, maybe for someone you love. You don't need to memorize medical textbooks. You just need to trust that when the signs appear, your instinct will be faster than your doubt. Stroke steals time, but awareness gives it back. Stay with me for just one more moment. Breathe in, let it out. Close your eyes. Think of a face you love. Imagine noticing one small change, an uneven smile, a slowed word, a sudden slump. Now imagine knowing exactly what to do next. That's the power of preparedness, and it starts with you. Hope this video is useful for you.